Imagine you take a nasty fall on a ski slope. You tumble, you hit your head on the hard-packed snow, but like a minute later, you're sitting up.
Right. You're probably just a little dazed.
Yeah, exactly. You brush yourself off, you joke with your instructor about being clumsy, and you just walk back to the lodge under your own power. I mean, to anyone watching, and even to yourself, you seem entirely fine.
You feel fine.
You feel totally fine. But inside your completely opaque, rigid skull, a countdown has already started.
A very fast countdown.
Exactly. So for anyone listening who has ever wondered how clinicians actually know what is happening inside that closed vault without, running a continuous MRI on someone, we are getting into the mechanics of the neurological assessment in today's deep dive. We are decoding the subtle physical language the brain uses when it is in crisis.
And the challenge of the closed vault is exactly why the neurological assessment is so rigorous. And I'd say the fundamental paradigm shift for any medical professional learning this is moving away from the idea of the neuro exam as like a static photograph.
Right, like a one-and-done check.
Exactly. If you take a single set of vitals or you do a single check of someone's pupils, you know virtually nothing about their true neurological status. A true assessment is a trend line.
A trend line.
Yeah. It is a systematic, highly repeatable exam designed to establish a baseline and then really ruthlessly hunt for deterioration.
Okay, let's unpack this, because historically, early neurology treated the exam a bit more like a treasure map, right? I mean, the entire philosophy in the early 20th century was purely diagnostic.
Oh, entirely.
The clinician was doing these exhaustive tests just to localize a lesion, trying to figure out which specific lobe or nerve tract was damaged based on whatever symptoms they saw.
Right. But the evolution of modern trauma and critical care medicine demanded something entirely different. Like when you have a patient surviving a massive car wreck or a severe head injury, the immediate priority isn't mapping the exact coordinates of the damage for a textbook.
Yeah, you don't have time for that.
Exactly. The priority is prognostic. It's surveillance-based. Clinicians need to know if the patient is decompensating right the second and, the velocity of that decline.
And that surveillance mindset makes the frequency of neurochecks in an ICU, which is sometimes every 15 minutes, make total sense. You are tracking a moving target.
You really are.
But plotting a reliable trend line requires the people plotting those points to speak the exact same language.
Yep.
And if you look at medical records before the 1970s, the language being used to describe consciousness was just a total free-for-all.
It was chaos. We had this incredibly dangerous communication vacuum.
Yeah.
And you can trace the origin of our modern standardized approach back to 1974 to Graham Teasdale and Brian Jennett at the Institute of Neurological Sciences in Glasgow.
Okay.
They were basically watching patients get transferred between facilities or just being handed off from a night shift nurse to a morning attending physician. And the charts were filled with these completely subjective adjectives.
Like what?
Well, a nurse might chart a patient as stuporous. A doctor might write obtunded. Another might use lethargic or semi-comatose.
Which, that sounds highly clinical, but I'm realizing that my definition of stuporous might involve a patient who groans when you nudge them, while your definition of stuporous might mean they're essentially unresponsive.
Exactly.
If the night shift and the day shift are using different subjective adjectives, it is just impossible to know if the patient's brain is actively swelling or if they are just, tired.
And that ambiguity was literally costing lives. So Teasdale and Jennett's solution was to completely operationalize consciousness. They stripped away all the philosophical baggage and the need for a clinician to make a subjective judgment about patients' internal state.
Right.
They broke consciousness down into 3 observable behavioral categories: eye-opening, verbal response, and motor response. And this became the Glasgow Coma Scale, or the GCS.
And it's such a recurring theme in medical history, this standardization born from sheer terrifying necessity. And the exact same thing happened with how we measure motor strength, right? Yes. That 0 to 5 scale you experience when a doctor asks you to squeeze their fingers or push against their hands, that didn't come from some modern research university. It actually came out of the UK Medical Research Council in 1943.
Right in the middle of World War II, they published a wartime pamphlet called Aids to the Investigation of Peripheral Nerve Injuries, because you had thousands of soldiers with combat wounds suffering severe nerve damage, and they were being moved across different military hospitals and field tents.
Wow. Yeah.
So a surgeon in London and a field medic in France needed an objective way to track if a soldier's radial nerve was recovering or deteriorating. So they created a simple numerical grading system for muscle contraction against resistance.
And 80 years later, clinicians are still at the bedside asking patients to pull against their hands and grading them a 4 out of 5.
It works.
It does work, but I have to push back on the philosophy of the GCS for a second.
Oh, go for it.
We are taking the entirety of human consciousness, literally the most complex biological marvel in the known universe, and we are reducing it to a 15-point behavioral checklist. It feels almost, I don't know, reductive to grade a human mind like a multiple choice test.
Well, it is entirely reductive, and that is, it's genius.
Really?
Yeah, I mean, the limitations of that reduction are significant, and we will absolutely explore where the GCS fails later on. But in 1974, the sheer utility of having a paramedic in the rain, an ER trauma nurse, and a neurosurgeon in the operating room all look at the exact same patient and agree this is a GCS-7. I mean, that revolutionized trauma care. You are not evaluating the soul. You are just evaluating whether the physical hardware is responding to the physical environment.
The hardware, okay, well, that physical environment is really the crux of everything we are talking about today. To understand why dropping GCS score is so terrifying, we have to look at the unique real estate it's measuring.
Correct.
Because the skull is a very unforgiving container.
It really is. We operate under what's called the Monroe-Kelly doctrine.
Right.
The skull is a fixed volume, rigid vault. Once the sutures fuse in childhood, it does not expand. So inside that vault, you have a very specific equilibrium of 3 components. You have brain tissue, arterial and venous blood, and cerebrospinal fluid.
And if the vault is entirely unyielding, and you introduce something new into that space, say a hematoma from a torn artery, or if the brain tissue itself becomes ischemic and swells, the physics dictate that something else must be crushed or forced out.
Exactly. But the brain does attempt to compensate initially, and this is a critical phase. When a mass starts taking up space, the brain can shunt cerebrospinal fluid out of the skull and down into the spinal subarachnoid space.
Okay, to make room.
Right. It can also constrict the venous system to reduce the volume of blood pooling in the brain. It is desperately trying to maintain a normal intracranial pressure, or ICP.
I always picture this like packing for a long trip, using a hard-shell suitcase that is already filled to the absolute brim.
Oh, that's a good way to look at it.
Yeah, and you decide you want to cram one more heavy winter sweater in there. You shove it in, you sit your entire body weight on the lid, and you somehow manage to get the zipper closed. For a minute, the suitcase is compensating for the extra mass. The volume is contained.
Right.
But the outward pressure on that zipper is immense, and it's only a matter of time before it violently bursts open.
And the moment those internal compensatory mechanisms exhaust themselves, you hit the inflection point on the volume pressure curve. The ICP doesn't just creep up, it skyrockets. And as that pressure rises, it threatens the brain's perfusion.
The blood flow.
Exactly. The level of consciousness, or LOC, is our absolute best window into that perfusion battle. It is the single most sensitive indicator of neurological decline.
Meaning it responds faster than heart rate or blood pressure changes.
Oh, much faster. The reticular activating system, which is located down in the brainstem, is responsible for keeping you awake, and your cerebral cortex is responsible for your awareness and cognition. Both of these structures are incredibly metabolically demanding. They require a massive, uninterrupted supply of oxygenated blood. If the pressure inside the skull rises even slightly, restricting that blood flow by just a fraction, those tissues suffer immediately.
So long before the physical structure of the brain is permanently crushed, the patient's behavior changes.
Yes.
They might just seem unusually restless in bed.
Right.
Or they suddenly can't remember what year it is, even if they knew it an hour ago. That subtle confusion is the brain's early warning system flashing red.
Which is why relying on a patient outwardly appearing fine is just a fatal trap in neurotrauma. If we go back to that ski slope scenario you opened with, you just perfectly described the 2009 tragedy of the actress Natasha Richardson.
Right.
She fell, she hit her head, she was totally lucid, she walked and talked, and she initially refused medical transport.
And less than 48 hours later, she was dead from an epidural hematoma. It is the textbook case of the talk and die phenomenon.
It is. An epidural hematoma involves an arterial bleed. Usually, trauma to the side of the head fractures the temporal bone and tears the middle meningeal artery.
And arteries are high pressure.
Exactly. Because it is an artery, That blood is pumping under high systemic pressure, and it begins rapidly pooling in the epidural space, which is between the inside of the skull and the dura mater, the tough outer membrane of the brain.
Okay, but if arterial blood is aggressively pumping into that tight space, literally peeling the dura off the bone, why did she experience that lucid interval?
Yeah.
Why was she joking with her instructors instead of immediately collapsing?
Because of the suitcase you were sitting on.
Oh, the compensation.
Yes. Her brain was compensating. It was aggressively shunting CSF and venous blood to make room for the expanding arterial pool. During that lucid interval, her cerebral cortex was still getting just enough perfusion to function. Her GCS was likely a perfect 15, but underneath that calm exterior, her compensatory reserves were rapidly draining.
And when the zipper finally broke, the arterial pressure overwhelmed the vault.
And the decline is catastrophic. The intracranial pressure surges, physically crushing the brain tissue downward toward the brainstem. This highlights why a single snapshot assessment is useless. If someone cleared her based on a single GCS of 15 on the mountain, they completely missed the plunging trend line that was about to occur.
Let's follow that physical cascade then. Because if you miss those early subtle changes in the level of consciousness, the restlessness, the slight confusion, the brain starts throwing out these late blaring mechanical alarms. Like if you watch any medical procedural show, you've seen the moment a doctor shines a penlight into an unconscious patient's eyes and shouts that they have a blown pupil.
The classic unilateral fixed dilated pupil. Yeah, in a healthy state, our pupils are equal, round, and reactive to light. Clinicians use the acronym PURE-RLA. They should sit anywhere between 2 to 6 millimeters.
Right.
But when intracranial pressure spirals out of control, the brain tissue has to go somewhere. And the only major exit from the closed vault is the foramen magnum, which is the hole at the base of the skull where the spinal cord exits.
Meaning the brain literally begins to extrude itself through the bottom of the skull.
Yes. There is a rigid fold of dura inside the skull called the tentorium cerebelli. As pressure builds in the upper hemispheres, the medial portion of the temporal lobe, the entecus, gets shoved forcefully downward over the edge of that tentorium. This is called uncal herniation.
Okay, and what exactly is the uncus colliding with as it gets pushed down?
It collides directly with cranial nerve 3, the oculomotor nerve. This nerve controls several eye movements, but crucially, it carries the parasympathetic nerve fibers that tell your pupil to constrict.
Oh, wow.
So when the herniating brain tissue traps and crushes cranial nerve 3 against the base of the skull, those constricting fibers are paralyzed.
Leaving the sympathetic nervous system completely unopposed.
Exactly.
So the pupil on that side just aggressively dilates and freezes there, completely unresponsive to the penlight, while the other people might still look normal. That structural asymmetry means brain tissue is actively shifting.
It is a profound neurosurgical emergency. Once you see a blown pupil, you will likely also start seeing severe motor abnormalities on the GCS. As the compression moves further down the brainstem, you see decorticate posturing, where the patient's arms flex tightly and rigidly inward toward their chest.
Like they're pulling toward their core.
Right. And if the herniation continues even deeper, damaging the vestibular nuclei, you see decerebrate posturing, where the arms extend rigidly outward and the wrists rotate.
At this point, the physical compression on the brainstem is just extreme. The vital signs must be reacting to this level of structural failure, right?
They do, and it manifests in a highly specific pattern known as Cushing's triad, identified by Harvey Cushing in the early 20th century. It consists of a widening pulse pressure with profound hypertension, bradycardia, and irregular respirations.
I want to break down the mechanics of that triad because it sounds like a massive physiological war between the brain and the body.
It basically is.
If the pressure inside the skull of the ICP is climbing to astronomical levels, the systemic blood pressure in your body has to rise just to overcome the resistance and force oxygenated blood up into the brain.
Exactly. If your intracranial pressure exceeds your mean arterial pressure, cerebral blood flow stops. The brain suffocates. So the ischemic brainstem triggers this massive sympathetic storm. It clamps down on peripheral blood vessels across your entire body, driving your systolic blood pressure to extreme heights, often well over 200, just to force perfusion into the vault.
But the second part of the triad is bradycardia. So why is the heart slowing down while the blood pressure is skyrocketing?
Well, baroreceptors in your aortic arch and carotid arteries detect this terrifyingly high systemic blood pressure. They signal the vagus nerve to slow the heart rate down in a desperate attempt to protect the heart and vessels from literally exploding.
Jeez.
So you have a slow pounding heart rate paired with massive hypertension. And the third component, irregular respirations, which is often agonal gasping, occurs because the respiratory centers in the medulla are just physically being crushed.
And the most critical takeaway here for anyone listening is that Cushing's triad and a blown pupil are not early warning signs. They are the physiological equivalent of the house already having burned to the foundations.
100%. Waiting for Cushing's triad to act on a head injury is medical negligence. By the time the vital signs reflect this triad, the brain has been in a state of severe decompensation for a significant period. Normal vital signs offer absolutely zero guarantee of a stable neurological status.
It's like relying on vital signs instead of serial level of consciousness checks is like ignoring the check engine light on your dashboard for weeks
Yeah.
and only pulling over when flames are physically shooting out of your hood.
Yeah.
The subtle confusion is the check engine light. Cushing's triad is the engine block melting.
That is the exact reality of neurotrauma. We rely heavily on the Glasgow Coma Scale to catch that check engine light to map the pressure changes. But, applying a behavioral tool designed in 1974 to modern high-complexity medicine, it exposes some massive blind spots. The GCS is far from a perfect instrument.
Yeah, and one of the most glaring blind spots has to be the intensive care unit. The GCS strictly requires a verbal response. But if you have an ICU patient on a mechanical ventilator with an endotracheal tube passing through their vocal cords, they are physically incapable of speaking.
Right, and this created a logistical nightmare for charting. Clinicians started improvising by appending a T to the score, logging a GCS 10T to indicate the patient was intubated.
Right.
But how do you mathematically account for the missing verbal score? If you assign them a 1 for the verbal component, which designates no response, you artificially tank their total score.
Which ruins the entire point of the trend line.
Yeah.
You're making them look significantly closer to brain death on paper than they actually are, just because a piece of plastic is in their airway.
Exactly. It severely distorts research data and clinical handoffs. And this frustration is precisely why Dr. Ilko Wijeks and his colleagues at the Mayo Clinic developed the FOUR score in 2005. They recognized that the GCS was uniquely poorly suited for intubated patients, so the 4R score entirely eliminates the verbal component. Instead, it incorporates detailed assessments of brainstem reflexes, like corneal reflexes and pupil reactivity, and it scores the patient's breathing rhythms.
But even outside the ICU, though, the GCS has a fundamental flaw, doesn't it?
Oh.
The people administering it. It suffers from inter-rater reliability issues.
Mm-hmm.
The motor component is fairly objective, sure, but grading someone's verbal response or eye-opening involves a degree of human interpretation.
Oh, absolutely. The literature is full of studies showing varied GCS scores for the exact same patient when assessed by different clinicians. The verbal domain is notoriously tricky. I mean, distinguishing between a patient who is confused versus one who is using inappropriate words is highly subjective.
Yeah.
Adding compounding variables like a patient who is severely intoxicated, or a patient who doesn't speak the clinician's language, or someone with aphasia who physically cannot formulate language due to damage to Broca's area.
A clinician might score their verbal response as a 1 or a 2, assuming their brain injury is actively worsening, when in reality, the intracranial pressure hasn't changed at all. We treat the GCS like a hard, objective laboratory value when it is heavily dependent on human judgment.
Which leads to the most dangerous misconception in neurological assessment.
What's that?
Many people assume that a perfect GCS score equates to a perfectly healthy brain. You could have a patient in the emergency department who spontaneously opens their eyes, converses fluidly, and follows commands perfectly with their right arm. They score a pristine GCS 15.
But they could simultaneously be suffering a massive ischemic stroke in their right hemisphere.
Exactly. The GCS was engineered to track diffuse trauma global pressure changes inside the vault that depress the reticular activating system and consciousness overall. It was never intended to identify focal, localized neurological deficits. A patient can have a perfect GCS 15 while their left arm is completely paralyzed and they are entirely blind in one half of their visual field.
Because the GCS doesn't require you to test bilateral strength, and it doesn't test peripheral vision. It is just the wrong tool for the job.
Right. And this is why tools like the National Institutes of Health Stroke Scale, the NIHSS, were introduced in the 1980s. The NIHSS is meticulously designed to map lateralized issues, deficits that occur on only one side of the body, and specific cranial nerve functions that the GCS completely ignores. Applying the GCS to a stroke patient gives you a false sense of security that could delay life-saving thrombolytic therapy.
Well, when you pull all these sources together, the reality of the neurological assessment is incredibly sobering. If you take away anything from this deep dive, it is that a neuro exam is a motion picture, not a photograph. The skull is an unforgiving vault governed by the Monroe-Kelly doctrine. And the absolute most sensitive indicator that the vault is running out of space isn't a blown pupil, and it isn't a massive spike in blood pressure. It is simply a subtle shift in how awake, aware, and oriented you are. Catching that slight behavioral dip is the only way to intervene before the physical architecture of the brain is permanently crushed.
The stakes are incredibly high, and it requires immense vigilance. But, looking at the history we've covered, from the 1943 MRC scale to the 1974 GCS, I am struck by a thought that extends beyond the current literature. We have been relying on the exact same behavioral scales for half a century because human observation was basically the only tool we had. We know inter-rater reliability is flawed. We know subtle changes in consciousness are easily missed by an exhausted clinician at 3 a.m.
Sure.
It forces you to wonder if we are on the precipice of a massive paradigm shift. With the rapid advancement of AI and continuous biometric wearables, are we approaching a future where the hourly bedside neurocheck becomes obsolete?
Oh, wow.
Imagine a wearable device that analyzes microscopic changes in your baseline vocal cadence or subtle delays in saccadic eye movements, detecting a drop in perfusion hours before a human nurse would ever notice you seemed confused. The secret language of the brain has always been translated by people, but perhaps it will soon be decoded entirely by algorithms.
From entirely subjective adjectives in a Scottish hospital ward to continuous algorithmic baseline monitoring, that is a fascinating trajectory to consider the next time you look at the biometric sensors on your smartwatch. Thank you for joining us as we unpack the rigorous, high-stakes mechanics of the closed skull. Keep questioning what you see, and we will catch you on the next deep dive.